Our last speaker, Dr. Sri Ganesh, does not need any introduction. Of course, we all know him as a very prolific cataract and refractive surgeon, a world-renowned surgeon who's contributed a lot to the field of refractive surgery. He has worked with probably every technology in refractive surgery, most of the excimer lasers. So we can't wait to hear his a talk on ASOCT-based tomography system, which is the MS39 essentially, an all-in-one refractive workstation. Looking forward to your talk, sir.
Thank you, and good morning, everybody. I would like to thank Dr. Sheetal for including me in her IC, and we will be looking at the newer modality. Let me just get this up. No? Okay, that's okay, leave it. So we'll be looking at the AS-based tomography. So all of you all are very familiar with the Schleimflug-based tomography, which is the most popular being the Pentacam. But the ASOCT has a few benefits over the Schleimflug. One is the resolution is much better, and some of the features. So I'll be talking about the MS39, which is a AS-based tomography system, which has okay. It's the most advanced device for analysis of the anterior segment, and the MS39 combines placido-disc corneal topography with high-resolution OCT-based anter-segment tomography. It is the resolution of is about 3.8 microns of the OCT, so it's a very high-definition OCT. And it also delineates epithelium from the total cornea. You heard Dr. Sheetal speak on the importance of epithelium. So with this, we are able to get epithelial maps. And it also has a 16 into 16 millimeter diameter. So it includes the entire cornea, even larger corneas up till 12 millimeters. So you get a complete analysis. So let us look at some of the applications of the MS39. The most important for us as refractive surgeons is keratoconus screening, because you don't want to do refractive surgery on the wrong patient. This was a paper which looked at normative data and keratoconic eyes, and they concluded that the MS39 is a very valuable equipment for diagnosing keratoconic corneas with a high accuracy for many of the parameters. So if you look at the keratoconus screening, it has what is known as notable point spread. In her previous talk, Dr. Sheetal Mavakar said that you have to look at the thinnest point, the maximum curvature, etc., and then match it. But what the MS39 does is it has what is known as the notable point spread, and it has various indices. Normal is more than 1, 0.6 to 1 is borderline. Less than 0.5, you have suspicion of keratoconus. So if you look at the notable points, it has the epithelial thickness, it's got the stromal thickness, it's got the total thickness of the cornea, it's got the Kmax, anterior Kmax, posterior Kmax, and the elevations. And it looks at all these points and it gives you the slider scale, and here you can see it is abnormal. And you also have a yellow circle and a red circle. If all these points are within the red circle, then it is highly suspicious of keratoconus. It also gives you this red flag that it can be a keratoconic cornea, and you can see here it is 0.19, so it's highly significant. And then it also has the indices. Indices include the NPS, the curvature indices, elevation indices, corneal thickness, and the epithelial thickness. And all of them have a slider scale, and if it's abnormal, you get a red flag. It also gives you classification of the keratoconus. It gives you grading of the keratoconus, ABCD grading, and also the morphology of the keratoconus. So here it says nipple type of a central keratoconus. It also gives you other parameters like the keratoconus center and the axis, etc. It also has something special known as the Gaussian curvature maps, which are more sensitive and truly morphological, gives you a true morphology of the pathology. So the geometric mean of the maximum and minimum curvatures at one point on the surface are taken to get this map. And if you look at this keratoconus summary map here, you have the anterior surface, the posterior surface, epithelial thickness, stromal thickness, and corneal thickness. So you can look at all of them. And it also has the Gaussian anterior curvature, Gaussian posterior curvature, and the epithelial thickness pattern deviation. This is what I was talking about. So you can see whether it is, how different it is when compared to the normative data. And even stromal thickness pattern deviation and corneal thickness pattern deviation. And here you can see that the Gaussian anterior curvature again is different from the tangential curvature. So it's a little more sensitive. And it also gives you the corneal thickness progression. And then it also has classification, and it tells you whether it's a borderline cornea or a keratoconus cornea, taking all these into consideration. You can also look at keratoconus progression. If you have two or more maps, then you can look at the difference maps between the tests, and then you can also look at different indices. You can look at the anterior curvature, posterior curvature, anterior elevation, posterior elevation, corneal thickness, and look at the graph here whether there is an increase or a decrease. You can also look at the difference maps. Epithelial maps are very important. Dr. Sheetal has already dealt with it. I think Dan Reinstein and his group did a lot of work using the ultra high frequency ultrasound UBM to look at epithelial maps, but now the ASOCT has a non-contact epithelial map with a very high resolution. The epithelium basically has a masking effect, so it thins out over hills like the center of a keratoconic cornea, and it thickens over valleys wherever there's a depression. And it has significant effect on corneal remodeling after refractive surgery. And with keratoconus, you can have what is known as the donut sign, where you have thinning of the epithelium in the center and thickening in the periphery, and you get epithelial maps with the MS39. So I'll go through some of the case scenarios. This was a 26-year female interested in refractive surgery. You can see that she's got a low myopia, 1.75 and 1.5. If you look at the pentacam, you can see that the bad as such, it shows that the patient has thin pachy of 458 microns, and like a form freste keratoconus picture on bad, you can see both the anterior and the posterior elevations are borderline, and if you look at the indices, they're all borderline or abnormal, and the total D also is kind of borderline. What happens is the pentacam gives more false positives for keratoconus, so it is the false positivity can be quite high, so it overdiagnoses keratoconus, and this is where we use the MS39 to look at whether this is actually a keratoconic eye or not. And if you look at this MS39, and all the indices, they are all normal except the thickness of the cornea, and the classification is normal. So you can see that the curvature maps, the elevation maps, the stromal elevation, corneal thickness is low, but all the other maps are normal. If you look at the epithelial map also, it's perfectly normal. It doesn't have the donut shape, so it classifies it as normal. And this is a thin cornea with a low power, so you can go ahead and do PRK safely in this eye. This is another case which is a 26-year-old male interested in refractive surgery. You can see again a low myopia with low astigmatism, and if you look at the pentacam, and it shows that it has he has a thick pachy, 561 microns, but the anterior elevation, posterior elevation on bad are abnormal. The total D, of course, is normal. So these are cases where which are perplexing. I mean, would you go ahead and do touch this patient, do a refractive surgery or not? And then we look at the MS39, and you can see that it's normal epithelial thickness pattern, normal classification. So the patient is suitable. You can, because it's a low myopia, you can either do PRK, smile, or even LASIK. and topo-guided treatment, cross-linking is not indicated. Of course, you can also use biomechanics, like Dr. Raghavendra said, to further confirm whether the cornea is normal. But the pentacam has a tendency to kind of overdiagnose keratoconus, and you will be rejecting a lot of your refractive patients. So this is something that you need to look at carefully. It also has advanced analysis of tear film, and this is a non-contact assessment, so you don't have to do your Schirmer test, or you can look at the non-invasive tear breakup time, and this is helpful for pre-op refractive evaluation. So you can see that it gives a tear film map. If it's green, it's kind of normal. It also looks at the first tear film breakup and then the average BOT. And this was an example of 25-year-old female with history of contact lens use for 5 years. And you can see that she has got minus 4.25 with one cil, other eye 4.75 with one cil. She wanted refractive surgery, but you look at the tear film. The tear film again shows that the first non-invasive T-butt breakup is at around 5 seconds, which is abnormal, but the average is around 10.3 there. So the first breakup is abnormal, and she has some amount of abnormality. So we stopped the contact lens, put her on lubricants, and managed the dry eye, and you can see how it improved. And you can see now that the tear film is much better, and the first breakup time and the average breakup time are almost at the same level, more than 10 seconds, which is normal. And the other interesting thing is, if you look at the K1, K2 values and her astigmatism, actually the astigmatism dropped from 1.5 to 1. So the tear film, when you have an abnormal tear film, it can induce some amount of cylinder and refractive error. So it's very important to treat dry eye before doing an assessment and taking up the patient. So that's how the MS39 helps in doing a non-invasive tear film assessment. It also gives optical quality analysis summary with the corneal wavefront, the point spread function, the visual simulation, and the MTF. So the corneal abrasions, you can look at it separately from the epithelial abrasions. So you can have a segregation, and you can just look at the, sometimes you can have epithelial abrasions which are more because of epithelial remodeling, and the cornea itself is normal. In such cases, you may want to modulate with medications like steroids for a longer period of time, and that's when it helps, where you can look at whether the abrasions are from the cornea, whether it needs further correction, topo-link treatment, or whether it's just from the epithelium, because the epithelium is temporary. It also has pupillography, where which gives you the static and dynamic pupils. You can have the scotopic, mesopic, and photopic pupils. It gives you the measurements. It also gives you dynamic pupil center. So sometimes you can have a what is known as a centroid shift. As the pupil dilates, the center of the pupil shifts. This is important if you are using an eye tracker which centers on the pupil for doing your ablations, and you can study that with this. It also gives what is known as dynamic vault assessment. This was a paper which looked at the ICL and the changing vault on pupil size, and this is something which is significant. The pupil changes as the vault of the ICL changes as the pupil constricts or dilates, and you may want to study that, especially in cases where which have low vault, and on the pupil constricting, sometimes the vault can further reduce, and you can have a touch and a higher incidence of cataract. This is just a short video showing that. You can see that when the pupil dilates, the vault is higher, and as it constricts, you can see it constricts now, and then the vault reduces. And this is on scotopic pupil, it is 266, and on photopic it's 227. So almost more than 30 microns, 40 microns difference in the vault. It also has advanced lens biometry, what is known as ELED, expected lens equator distance, and lens thickness, depending upon the size of the capsular bag and the lens thickness, and this gives you the predicted lens position. It has also ray tracing biometry, so it has the CSO software for ray tracing, And this is a patient who had undergone LASIK. She had a refractive error of -14, 1.5 cylinder, developed cataract. Now these are cases where you would want to be a little more accurate. So we do ray tracing along with the other biometry formulas like the Barrett True K and Barrett True K TK. And you need to put in the axial length in millimeters. You can measure it either with ultrasound or an optical biometer. Then the target refraction, pupil diameter, and A constant of the lens to be implanted. And then it gives you the IOL power for, you can see here it is 9 diopters, 10.5 diopters, and this is the residue. So this is also a useful tool in the MS39. It also has software for planning intrastromal corneal rings for keratoconus, and it has imaging, the ASOCT, where you can look at the rings or even flaps, etc. So it's a high resolution OCT which you can use for all your corneal work. To conclude, the MS39 has multiple functions: keratoconus screening, selecting patients for refractive surgery, or choosing the best ICL surgery parameters. It also gives you lens size, which is important now for deciding ICL vault. Enables anterosegment surgeons to better understand the patient visual issues, choose the most appropriate course of action for them. Thank you very much for your attention.
Thank you, sir, for a very insightful talk on MS39. I think we have finished right on time, 10:25. Do we have any questions from the audience?
Sir, you said the pentacam tends to overestimate the keratoconus, but I think it is only limited with the smaller white to white. What are the other parameters? Because if suppose the patient's white to white is between 10.8 to 11.4, then I have seen that it tends to overestimate the keratoconus. But apart from them, is there any red flag sign? Would you like to say for the pentacam? Because majority of are having the pentacam.
Majority of you all have. There are also studies which have looked at the false positivity and specificity and sensitivity of the pentacam. So you can have a high overdiagnosis of, it's almost about, the specificity is about 67% or something like that. So sensitivity is about, if it says it is normal, that means it is very unlikely that it is an abnormal cornea. But if it says that it may be a keratoconus cornea, there is almost 33% chance that it can be normal. And this is not only for small corneas, we see it on average corneal diameter. So this is something that you have to take care of. The other thing is you also have to look at the angle kappa, because sometimes when you have a large angle kappa, then you can have skew, you can have inferior steepening and in a normal cornea. So these are some of the fallacies of the pentacam that you should be aware when you are interpreting the scans, and don't take it on face value. The badly. This is what, because we looked at the other scans also, and sometimes, like I showed in the examples, it can be normal. So you may kind of be sending patients away whom you can treat.
So I think you need to have the ASOCT now in your practice.
ASOCT based, or you should at least, like I said, reevaluate and look at it and see whether it's actual keratoconus or whether it is the error of the software, especially for the bad screening.
See, having ASOCT for all of us is next to impossible. So that's not the way to go about it. If you have any doubt, and one parameter in pentacam is never to go by, but you can always repeat the topography and see whether it is consistent. If it is consistent over a period of time and there are no changes, you can safely go ahead with surgeries. And if you want to be still on a safer side, obviously surface ablation is the answer.
The pentacam became popular because of posterior elevation. Because what happens is keratoconus actually does not start on the posterior surface of the cornea. It starts on the anterior. The changes are first in the Bowman's layer. But what happens is, because of epithelial masking, you can't see the changes. Because in the topography, in most of the Placido-based topographies, it's basically measuring the tear film. And with that, because if you have epithelial masking, it looks normal. So you take up and then you have ectasia. But even if the anterior surface is normal, because of the epithelial masking, the changes in the posterior surface are picked up by the pentacam. That's why the pentacam became popular. But then it has its other issues.
Yeah,
so
like the curvature maps of pentacam, they are like mathematically driven. So they are
Yeah.
not really very good, unlike your Cirrus or this thing. Cirrus is Placido based.
That's
The
why they
curvature
included
maps of
the
Cirrus are
Placido.
better. Yeah.
because the The
So
curvature maps, the sagittal maps which you get are kind of
Yeah,
derived
mathematically
derived from
derived
the elevation maps.
elevation